a podcast by respiratory leaders for respiratory leaders. This is RT Sidebar. Stay tuned.
All right. I hope you guys are ready for today. I've been waiting for this for so long for Jonathan and I to come bring on great friends to really expand our network, expand the reach of RT Sidebar. We are kicking ass in RT Sidebar right now. Downloads, great feedback. Really, RT Sidebar has been Jonathan, just been special to both of us.
Yeah, it really has. It was, it was a nice dream that we didn't think would get this far, and to see
Jeff,
where it is now from where it started. I mean, this is a dream come true.
So part of that dream is bringing on great friends. And over the last year and a half of RT Sidebar, we have two people that are really special to us. And they have a great network of people. Plus, they bring perspectives that are different. JB and I think very similar. We just do. So getting some diversity of thought with some good friends so we can argue and have good banter. So I am happy to introduce our two guest hosts today. Number one, Mindy Conklin.
Hi.
APRT extraordinaire, Baltimore, VA, from something that starts with a V.
The Ohio State University.
But we love you. She is the advocate for the APRT program, AARC, MBRC, just kicking butt. Mindy, thank you so much for being on. This is your third?
Yeah, my fourth.
Yeah, because I screw things up.
Yeah, we had to retalk one. Back at AARC last year.
AARC. But no, Mindy, it's an absolute pleasure. And really, you brought up this topic. So we're going to get into that after we introduce our other friend, JJ the RT, JJ Valdez. It is wonderful to see you, my friend. The graphic in the back is phenomenal. We are collaborating. JJ has been a great friend of RT Sidebar. Probably the first time Jonathan ever cried on RT Sidebar was with JJ.
Wow.
I think he cried with me too.
I think he did too. He's a sappy guy.
A big softy.
Yeah. So JJ, you're down at Victoria College. You are teaching students every day. You're our educator extraordinaire. Plus, you're married to Alicia that keeps you where you need to be at all times. And I know she's on the other side of the camera, which makes me happy. But it's great to see you, my friend. And as always, Dr. JB, it's so good to see you, my friend, between two eucalypti. How you doing, bro?
Good, good. Making sure that they stay watered so they don't collect dust, but it's good.
So, my friends, Mindy drops a bomb on what this topic is, and woohoo, it's going to be a fun one. It's going to get interesting. JB, do you want to give us some context on where we're going with this?
It's a great topic. I'm on my way out of probably the profession, and then I see respiratory students coming into the hospital every single day, day and night. And you always wonder, like, okay, well, this is the future of our profession here. Are we handing over the profession or the keys to the profession properly, giving them everything they need, support, education, courage? Are we treating them right? And, that's a very touchy subject because sometimes they are, sometimes they are not. I did clinical education for about a year, and I swear I did everything other than clinical education because my students were not being treated properly. So I know it happens, and it happens often. And it kind of makes you think about when nurses eat their young, are we doing that same thing to our young? And so it's a topic that we should all talk about, discuss, and shine some light on. So Mindy, I mean, where did this topic come from for you? Did you see something or?
Yeah, so I take this topic really personally. You know, our profession, we're in trouble. We're going to be short 40,000 RTs by 2026, I believe.
2026, yep.
And we need to do better as respiratory therapists, as a profession, step up and recruit, but not only recruit, we need to put our students first. We need to give them the clinical education that we had, that we would desired as students, and that doesn't always happen. So yeah, I'm excited for this podcast to see what we can come up with.
Absolutely. Hey, JJ, you send students to
Yeah.
clinical. I mean, that's your job, is to prepare them to be students in the future. Is this something you worry about? Are they getting the edge? Are they getting the experience that you're hoping for? Is this something you worry about every day?
You know, what's crazy is there's different experiences everywhere you go, right? You go to a major teaching hospital, you're going to have a different environment and a different culture versus a rural hospital that has one medical director that says it's my way or the highway. And there's such a dichotomy of what the students can go into, but they also need to realize, like, that's the environment that they're going to go work in if they choose to go there. So one of the things that they have to do is recognize that not only are they on a job interview every time that they go,
Yeah.
but the facility is on a job interview every time that they go as well. So that's as much encouragement as it is, cracking the whip to all the listeners, because as you take on students, they're seeing what you do. They're seeing what you do, and they ask their professors, they ask their educators, "Hey, what's up with this? Why is it this?" And
Yeah.
we have to come up with an answer for that, and sometimes we just have nothing for them.
So this is what I have.
Matt, let me jump in real quick,
yeah,
Matt,
please
'cause
go ahead, man.
I want to ask your opinion on this too, because I was just thinking about it. You're a leader in the respiratory department. You have very little interaction with students. Usually someone else is managing the students. As a leader, how would you know if you're failing or if you're succeeding in the management of your students?
Wow. Wow. Okay, JB, you're going to start this way. All right. I see where you're going. So this introduces our conflict. So I don't take students regularly when I was a department director, but I had a director open door program. So if students wanted to come in, like I love students. I have no problem letting a student do my work. I have zero problem with that at all. When I look at what metric,
That's not what they're there for.
that is exactly what they're there for. Scaring the crap out of them. And wait till you hear Mindy's story. I can't wait till she tells. Scaring the crap out of them, getting that adrenaline rush, and then they know they can do it. Oh, I love that. Oh, but when I look at how students are treated, the easiest way to look at, and JB, you gave me a softball here. Am I filling positions? Are the students staying at my clinical site? So that's my metric. But does that happen? So I'm going to go, Mindy, and I'm going to say, okay, you're a student and you've seen it. Oh, you're going to have a student today, and you could see the crappy face that people, oh, you got to be kidding me. But tell us a story. Tell me the story you told me today of why it's so important at a human level to give a student a great experience. Like, how did that motivate you? Tell us the story you told me earlier today, because it's fantastic.
Oh yeah, so it was my first clinical rotation at the Ohio State University, and I was in the medical ICU, and my preceptor, Rachel Weed, I'll give her a big shout out just right now. I was with her for the day, probably the first time I was ever in the medical ICU, and there was a bedside trach that was about to happen. And I remember her pushing me into the room and said, "Go to the head of the bed, hold that tube." And the physician, the pulmonary doctor who was doing the trach, was like, "If you lose this airway, he dies." And I'm up at the head of the bed. I'm nervous. This is my first procedure I've ever been in. I'm watching everybody. I'm gowned up. I'm sweating, holding this ET tube. My preceptor's outside the door because this was a very small room. So there's not a lot of room for everyone. But I listened intently. I watched everything they did. When they told me to pull the tube back a centimeter, 2 centimeters, I paid attention, tried to look, sweating, shaking, pull the tube back. But it was honestly the best experience that a student could have. So from that moment, I thank Rachel for being so pushy and saying, hey, just do it. And I've never been one to back away from anything, any kind of challenge or anything in my professional life. So, I jumped at that opportunity, and it was something I was very excited to bring back to school and be like, hey, I helped with this bedside trach today. And I felt that, if I had students from that point on as an RT, that I wanted to give them the same experience. So I made sure when I was a preceptor that I was that Rachel Weed who put my student therapist in positions where they can learn and be confident and build that confidence as an RT, and you start to use their critical thinking skills. Yeah, so that was probably the best clinical experience that I've ever experienced, and it stayed with me.
So it stayed with you. So
Yeah,
a good clinical experience
Mhm.
stays with you,
right.
but a bad clinical experience
It stays with you
can
also.
also stay with you.
Yeah.
So, Jonathan, tell us a story. You've been with students a lot lately. For some reason, they give you students like every day, and you're like, "Come on, let's go do it." Like, what is your mindset as a preceptor to do and create an experience like that? And then JJ, I want to come to you and say, what is it that you hope that we have when it comes to these type of experiences? So JB first.
For me, what I like to do is I like to get the ones that it's their first rotation into the hospital
Mhm.
because they're terrified, but I like to remind them what they're there for. So, they go in and they're looking at me, with huge eyes, like, what do I do? And it's just like a treatment or something. But my first thing is not like check their pulse ox, not listen to their lungs, not any of that stuff. It's interact with them, right? Interact with that patient. Remember that you're actually there treating a person, not just a mannequin or, and to humanize the role. And then also too, to like get, have that communication and then ask them about their life. Is there anything in their life at home that they're could do better to not end up in this hospital? For example, we're out in the desert and you can look out the window and there's mountains in the distance, but when the wind is kicking, there's so much dirt in the air that you can't even see the mountains. So maybe should you tell this patient, hey, do you have a HEPA filter at home? Stay indoors if you're asthmatic
Mhm.
or something like that, but have those interactions be there and humanize that role. That's kind of what I push on the entry level student right in the door because I didn't really get that when I was a student. I remember walking into a hospital and they looked up and they were like, "Oh, we have students, cancel registry," right? Because now we have a workforce here that's free and we don't have to pay extra for it for registry. And it's like, I was out there doing the job on my own with no guidance, no one to help, coach me or teach me anything like that. So that good support network and reminding them what they're there for is the good key to entering the profession. So, JJ, I mean, from the next level, what would you suggest for those students who are progressing into like the more advanced, like ICU or NICU rotations?
Yeah. So for the ones that are progressing into the ICU, I kind of go back to when I was on the floor and when I graduated. I graduated in the time frame that the ideal body weight and the desired tidal volume was 8 to 12 mLs per
That's because
kilo.
you're old.
Yeah. I used to say I'll never get there, but here we are.
You'll never
Right.
pass me,
So,
brother. Never pass me.
but when I graduated, that's what my boards said. Like, and I did my
Mhm.
math and I did everything that I needed to set up my patients on 10 mLs per kilo because that was the easiest math. Not because that's what was best for my patient, but that was the easiest math. But then as I continued to progress and start working on my bachelor's and start going to conferences, I actually heard Dr. Kazmarek speak, and he spoke on his study that he did from all mammals when he looked at a chipmunk all the way up to a blue whale. And it said that the average tidal volume for all mammals are 6 to 8 mLs versus the 8 to 12 that I had known. And I was that therapist that would dig my heels in. I would dig my heels in and say, you know what? I passed my boards and it was 8 to 12 mLs per kilo. I didn't know about the new evidence that had come out. So one of the things that students are getting is they're getting the latest and greatest when it comes to evidence. So some of the students are coming and they're asking questions about, you know, sedation practices and decisions with tidal volumes or modes or strategies when it comes to taking care of patients in these more critical areas. And they're coming asking the questions. And make sure that you can speak to make sure that you can speak to your decisions and that it be an evidence-based decision and not simply what you've always done, because the students are wanting to know more information and they want to know why perhaps local practice says this, but the national standard says something else. And I just say make sure you know what you need to know, because the students are asking.
So you're talking about ideal state, all right? JJ, you're always like, this is where I want everybody to be. But are we there? You know, when
Oh
you
no.
when we're
I mean,
taking care of students, go ahead, JJ. I'm sorry.
I told the story because I'm a clear example of not being in an ideal state, right? And I had to have that rude wake up call that said, "Hey, this is not what we're supposed to be doing."
Mm-hmm.
Um, I, Dr. Kazmarek was not a mentor of mine, but I did go to his talk and it opened my eyes. So having somebody that is bringing the information, like a podcast like this, that's bringing the latest information that people can kind of chew on and then apply into their practice, is something that we have to do a whole lot better job of.
So is that
I got to ask Mindy a question.
go ahead?
Yeah.
Go ahead,
So
JB.
you actually had another clinical rotation for APRT, and you knew better then. Did you receive everything that you needed in your advanced clinical rotation?
Oh yeah. So as a student, I did. I was fortunate enough to be able to have the pulmonary attendings to be my preceptor. So you know, when I told the story about the intubation during COVID, and the pulmonary attending was like, "Well, we'll get the fellow to intubate." That's when I jumped in. I was like, "No, no, no, let me do it," because I'm eager. I know I can intubate. I've done it as an RT.
Mm-hmm.
But he's like, "Okay, well, if you're going to intubate, you're going to run the whole entire um, scenario. So
Yeah.
order your medications. What are you going to do for sedation? What kind of tubes are you going to use for intubation? Get the whole lineup stuff." So it was very awesome to feel the good trust and collaboration that we had with each other, where he gave me the segue to kind of do what I know that I needed to do to show that I was competent to be an APRT.
So did you receive the education in a different way or format from a physician as you did when you were in your respiratory basic respiratory clinical rotation?
So my clinical rotation as an RT, I did most of mine, there at Ohio State. I always say Ohio State. But I did go to other facilities in Ohio, and I did receive different clinical outcomes when it comes to that and how you were treated. And some the clinical instructors weren't as caring or thoughtful when it come to my needs as a student, and they would leave me behind, or just sit there, park, and be on their phones, find other things to do other than precept me. And I was one willing to learn and do just about everything. But some hospitals, RTs are a little different than my experience that I had when I, went to Ohio State and did my clinical rotation at the hospital.
Do you think so? Working with Jessica is my boss. She's a physician.
Mhm.
She's an educator. She's a professor. Do you feel like, I always feel that physicians and advanced practice practitioners like yourself care or value education and that experience more than an entry level practice? Do I see that?
I don't see that per se. There's a lot of RTs like myself, who was a clinical preceptor, who care a lot about our students and our student education. Without our students, we have no future there's no
I
future.
believe that you.
And then, we're all talking about wanting to advance the profession to the advanced practice RT, but we have to have RTs practicing and coming into the profession in order for us to move to that next level. So we have to care for our own. We have to
Mhm.
jump in. We have to offer these students the best clinical education that, we can offer. And we might have a bad day. We might not feel the best, but that student is there to learn. And it's our job and to jump in and teach this student respiratory therapy.
Okay. Thoughts, guys?
I'll let JJ go on this one.
Yeah. So the expectation that we have for our students is to come out feeling and knowing that they can be a competent therapist whenever they graduate. And when we teach, we do not teach to the minimum expectation of what an RRT credential is. We teach to an APRT level or an ACCS level and an NPS level. So
Mhm.
we expect our students to operate at that level too. So when it comes to finding ways or areas to build that critical thinking, what I do is I open up the classroom, and the first 15-20 minutes of class, I always ask, how is clinic? And then they'll give me a scenario, and then we can tear it apart, and then I ask them, how are you going to do, what are you going to do differently next time? And so it comes back to, what are the facilities kind of doing? What are the preceptors doing that are helping bring our students to that level? And I kind of have the question, and I think about, like, are you operating at an ACCS level? Are you operating at an NPS level? Or are you simply working at the level that you were when you graduated? I've heard it said that people may have 15 years of experience, but is it that first year repeated 15 times, or have you grown 15 times over in those 15 years? And so that's kind of where I sit with that is, where are we? Where are we? Are we continuing to grow? Are we, Matt sings the song, the children are our future, but they truly are. And if you can control and develop the future of the profession, then you have way more confidence handing the keys over. As you kind of said at the beginning, you have way more confidence to hand those keys over whenever it is time for us to shift the control.
I like to look at all the other professions and steal from them whenever I can. When you get these new grads and they come in, you hire them, and they're just starting off. Do we give them the education and support to start in the hospital setting, or do we stick them on the floors for 6 months and then let them build up like their experience? But if you look at like nursing doesn't do that, right? They have the Versant program.
Mhm.
And you can come in from
Yep.
a new grad, pick a specialty, and you're going to be with another nurse for like 6 months. That level of support doesn't exist in our industry, but should it? Because, imagine what we can do in the NICU or in the ICU setting when you had 6 months of Versant training after you've gotten your license and hired on somewhere.
Yeah, I'm gonna throw some shout outs there because I know the Ohio State
Mhm.
is starting a respiratory residency program
Yeah.
where
Yeah.
they're really putting their arms around. Big shout out to Memorial Hermann does the same thing, but that's two that I know of. There's not a lot. It's a really good and interesting thought that you have. This is what I see. I see respiratory therapists teaching students to be respiratory technicians.
Mm.
I see, here's how you do the task of respiratory therapy. And what bothers me and why I wanted to talk about this so much is the task of respiratory therapy will be our downfall. It could take our whole profession. And Mindy, that's why you being an APRT is challenging the norm. JJ's talking about challenging the norm.
Mhm.
what should the new norm look like? Like if we can sit here and complain about, hey, we have therapists that just don't want students, but what does good look like? And what I learned is there's a student part, there's an educator part, there's a leader part, and there's a respiratory part. So what does or should good look like? Get us started off.
What should good look like? I think every RT should be prepared to take students. They should know coming in to their job that there's going to be students coming through, whether it's a community college or a 4-year program, but they have students. Sometimes they have nursing students shadow them. I know that's a very common thing, pharmacy students. But our RTs need to step up, and we need to start showing our students how to be respiratory practitioners, how to go the extra mile, show them how to get involved in rounds. Ask questions even if it doesn't pertain to respiratory therapy. And maybe your patient in the ICU has a head bleed. Ask questions, that way they can kind of get an idea. Okay, well, they have a head bleed. Well, how do you treat that? What do we do? Do we need to do an airway? Get the balls rolling in their head so they can start thinking outside the box, start building their critical thinking skills. So then they can grow. And when they grow, they want to continue to learn. So I'm going to hold RTs accountable. I'm
Okay.
going to say it. I think that we can do better.
JB?
I agree with Mindy. At my last organization, I did have some RTs that would say, I'm not taking students, I don't get paid for this. And I just told them it's an expectation. This is going to happen. You don't get to refuse to take students, because providing education to the next generation is just only one part of it. You should be providing education to everyone you come into contact with: nursing, physicians, the patient. Education should always, it's just a standard. It's what you're supposed to be doing anyway. So to say that you're not going to provide education is a dereliction of duty, because that is what you are there for. You are the professional in all forms of pulmonary and respiratory. I mean, this is what you have to do. It's just part of the job. So I don't even accept it as anyone to be able to say that, because it's just what you're there for. Because how many times are you going to run across a nurse who put a non-rebreather on at 4 liters, right? They have no idea why they did that. They just felt like, ooh, I don't want to do 15. That might be a little too much. I just put 4, but it's a non-rebreather. They have no idea. That's what you're there for.
Yeah.
You're there to like correct the situation and educate the nurse, so then they don't do that again. Because if they do that again and no one happens to check on that patient, then what happens to the next patient? And so you are there to educate. And so just embed that into your work life.
Wow. So let me play devil, or JD is going to about ready to play devil's advocate. Do you want every therapist teaching your students today?
No,
Why?
no, I don't.
Why?
Well, it goes back to an experience when I was a student.
Tell us about
There was a time before, it was in my first semester of school. I had not even learned about tracheostomies, or what a tracheostomy tube was, or even what trach care was. And even though I am kind of a forward thinker and I like to experience new things, this was a brand new airway and it was icky and I wanted no part of it. Right. But the
I don't want any
leadership,
part of it either.
the leadership and the team lead that day was like, JJ, you're going in there. You're doing that. And I was like, we haven't even learned anything about this. This is not like, but it wasn't a, hey, this is a great learning experience. It was, you're going to come do this with me. And I was so concerned about like messing something up, almost like what you talked about, Mindy, with hanging on to that airway and someone saying this is life or death. Well, this was a long-term trach, but I didn't know the difference at the time. And they said, you're coming in and you're doing this. And I flat out kind of threw my hands up and I said, you got the wrong guy. And so in my evaluation, they said I was refusing to learn new tasks. And that left a sour spot for that facility and for that person for a really, really long time. And so those are the people that like sour the entire patch. They're the ones that mess up the entire bunch when it comes to people coming through. Um, so there are some things that you want to kind of shield students from, but they also need to know what is out there. It's not all rainbows and cotton candy. There are some situations where you're put into a space and a place where you need to kind of buckle down and step up and take care of the patient, even if, you're there. But, in Mindy's situation, she had the preceptor there with her. She had the attending there with
Mhm.
her. They were trying to send me into the room by myself.
Oh yeah.
Oh
I was
yeah,
like,
that's a no-no.
Yeah,
yeah,
and that's just dangerous.
Right.
sure.
Like flat out dangerous. And so I know where I want to go with this, and I'm trying to ask questions instead of just tell my opinion. So do we all believe that it should be a core competency of respiratory therapists to be educators? It should be. Do we all agree?
I think it should be in the
Yeah.
job description.
I think it should.
Yeah.
Do you agree, JB? Same thing?
Yeah, and this doesn't fall under other duties as assigned. This is a core
Core competency.
part of the job.
So if we all believe that it should be a core competency, and JJ's telling us that there are people that don't have this,
Mhm.
what do we do to get them there?
Education.
Education.
Education's a big part of it. You will have those RTs that do not want to precept. That's okay. But say you're very short staffed and you have 5 students, that RT might end up with that student.
Yep.
Whether they like it or not, they're going to have a student for the day. But I also want to tell the students that they need to step up too. If they're sitting down and not performing tasks or refusing to do an MDI because they've done 100,000 of them, every scenario for an MDI could be different. You could walk into that patient's room and that patient be unresponsive, and that's a new scenario for you. It's a way for you to learn. So students need to step up to ask questions to the preceptor,
Mhm.
Ask if there's something they might be able to go see in another unit, whether it's like an open heart surgery or a lung transplant or something different than what they're stuck in and just stuck in a chair doing nothing. So it's up to the students, I think, too, to be proactive, to make the best out of their clinical experience.
Okay.
You
What
know,
else?
for a student to go into a room by yourself is the equivalent of driving a car before you get your license.
Agreed.
From a regulatory and accreditation standpoint, they're both violations. I mean, it's to the point where even a new hire that came on who's been licensed for 20 years technically should not touch a piece of equipment until their competency. So imagine not even having a license. So, it's really, the students should be aware that they need to speak up in that situation, because it's like asking them to drive by themselves with only a permit. You just can't do it, and they need to speak up. So in that situation where they were trying to throw JJ into the trach wolves, would have been a regulatory violation.
So safety,
Mm.
education. What else? JJ, what else do we need to get
I
to
mean,
that? This should be a core competency.
it's got to be a culture in the department. You've got to create
That's what I was
you've got to
looking for.
create that culture. If you put it in your competencies or in your job description that you are it is a core competency to educate, then you need to have a competency with it. So what are you doing through your daily course of work that shows that you are competent in education? How are you doing that? How do I evaluate that whenever I'm rounding? And I'm talking to my managers and my leaders now. When I'm rounding and I'm observing my staff, is that staff member educating that patient on the best delivery for that MDI? Are they educating the patient on the effects of the medication? Are they educating the patient to what they need to do whenever they go home for their disease process? Right? Those are the ways that they can then show competency, and then that will trickle down into it being a culture so that it comes natural whenever you have students. It's like, ooh, I've got a fresh painting here or a fresh canvas that I can make a masterpiece with. And that's what the students are. They're a fresh canvas for you to help mold, for you to help build.
Well, and if you don't do it, they're going to get molded somewhere else when they graduate.
Mhm.
I mean,
Sure.
that's the thing. Oh, we need more staff. We need more staff. We need more staff. But you're not giving a good clinical experience to your students. So, like, if they right when we started, JB, how do you measure if you're good at giving a good experience? What's your vacancy rate? If it's garbage, that's why. You know, I know some places that don't accept students. Like, are you insane? Like that,
Mhm.
like, and that's the stuff that drives me nuts. So going back to this, because I believe that we're onto something. It should be a core competency because it is a core competency with physicians. It is. If it's going to be a core competency, how do we get people to there? Okay. So educating patients and students is a core competency. Do you guys know that the ARC has a preceptorship program?
Yes, I took it.
Yep.
It's fantastic.
Yeah.
It is fantastic. It teaches about modeling, education models, how to work with adult students. Like it's a really good competency. I know one of my friends here is Jen Mahone. She's from Reading Hospital. In their clinical ladder, they added the AARC preceptorship program as part of their clinical ladder. I'm like,
That's a good idea, actually.
that couldn't be any
That's
easier.
Yeah.
You know,
That's creating culture, though. That's
that's
creating the
creating culture.
culture of the environment of the department. And but there's also hospitals and departments that don't even have the career ladder to start with. So we've got to find where our launch point is so that we can get to that. And everyone's launch point's different. But I mean, I love that they added the preceptor model into the clinical ladder. One of the places that I worked at, whenever I was the hospital educator, we had, if you are a preceptor, it gave you a bump in the clinical ladder. So um, how do we get that into the hospital? You have to have champions who do it. You have to have
Mhm.
the people that are willing to lead the force, and you have to have people walk the walk. If they're walking the walk, then they will trickle down. That will trickle down. I was a traveler at a hospital, and the RTs didn't attend rounds regularly. That's just the culture of that hospital.
Mhm.
But the culture of JJ was, I'm going to rounds, and because there's things that I need to know about, and there's things that I can interject with the information that I have. And slowly but surely, the time that I was a traveler, we started getting more and more of the staff that were attending rounds just from somebody doing what they've always done.
What's your thoughts about doing that preceptor program while they're in school? That way they kind of have like an outcome. Like you give it, you show them, they do the course and they kind of know what to expect as an RT.
Wow. So I went to the Mansfield University.
The Mansfield.
I didn't have
Uppercase or lowercase t?
it's very uppercase T. And we didn't have educational training,
Mhm.
but it was expected as a second year
Mhm.
to help the first years out. It was expected. And that's longer than I want to say, but if we want it to be a core competency, maybe it should be just as ACLS and
Mhm.
NRP education and understanding educational theory a little bit, understanding what makes a good experience or a bad experience. JJ, for your students, would that give them insight on what they should be looking for from a preceptor as well? So we have accountability both ways.
Yeah, I think it's a fantastic idea. I was thinking about where I can implement it into one of my classes.
Yeah, how you're
Um,
going to shoehorn it into your curriculum, right?
yeah, I mean, I can put that into my clinic class real easy and make it a module that they have to turn in the certificate for.
Mhm.
And by the end of the first semester, they've gone through that preceptor program. I mean, I think that's a fantastic idea, and it gives them insights as to what to expect, because the first 8 weeks or so, the students are for our program are pretty shielded with the clinical instructors or myself, or they're in the sim lab with CC. Shout out CC, we love you. And so they're in this kind of bubble of the Victoria College kind of arm reach. But after those first 8 weeks, they start going out to outlying facilities, and that's when we start running into more of the, oh, this is what we really do. This is what it's really like.
The
And
MDOC or the real world, right? They're two different things. Those two different things aren't that far apart anymore. They're not.
Right. So going through that preceptor program, I think it would be really good, because each clinical shift, the students evaluate the facility and they evaluate the preceptor, and the students get evaluated as well. So it would bring into alignment and help them understand exactly what is being evaluated and why.
Yeah, I
I
think
love
it's a
it.
great idea. It just like you could even TMS is what we call them at the VA, but CBLs is what we called them at where I worked before. So it's like you have to do yearly training, check-offs, whether it's like the sexual harassment training that you have to go through, or fire
Yeah.
safety. Why not make it preceptor?
100%. And then JB, that would check that box regulatory and safety wise, right?
Yeah. Yeah. I mean, just having a more structured program for students. If you understand that your department is terrible and no student wants to work there, you probably won't be invested in it. But if you know that most of the students that come to your hospital for their clinical rotation are future employees, why not start early? Start that structured program of education and competencies early, and then just continue it on when they hire on. Because then now you're getting a lot stronger of a student right out of the gate.
Wow. A lot to think about.
Yeah.
So JB,
Every time I come on this show, I either have more work to do or my students do. So I love it.
But that's a good thing.
that is always our goal. Jonathan, we started this podcast and now we have our friends on, but it was about respiratory leaders discussing respiratory leadership topics. With your final thoughts today. So we talked about we're in trouble. We could do better. This is a glimpse of what a good outcome looks like. Jonathan, you're an RT leader walking into a brand new department. What are 3 things that you would do to start that culture off the right way as a leader?
Oof. I gave you a softball and you throwing me like
I know.
on our pitches.
There you go, bro. I like it
Really,
bullet-pointed.
you just bringing everyone together and talking to the staff, you can kind of get a good idea of what that culture's starting to look like based upon everyone's reaction to you. There were some hospitals that I would work at where if you came in a suit, they would like hit the close button on the elevator as you're walking up, as opposed to like, I'd go into that same hospital in scrubs and they'd like hold the door open for you and then bring you in. It's like, that anti-leadership culture, it's going to be a very tough one to enter into, because as a leader and you're trying to make change, that's a heck of a resistance to go up against. So kind of just what are the personalities of the staff and how do they feel about a new leader walking in?
Okay.
You're going to kind of gauge how easy it is for any change management to occur. And then after that, you just look at attendance, right? So then if you have a ton of sick calls, there's a lack of respect for that department, because if they don't want to show up or they don't care about showing up, that's really what they feel like about that department. And then just quality measures after that, right? Is everyone doing the same thing? Is everyone really going out there and trying to provide the best quality of care? Or are they making every shortcut, under the sun so they can get more department time or RT break room time that they can? right? So
Absolutely.
that's kind of the first three things that I would look at to get a good gauge on that culture.
So initial cultural assessment. Then you're thinking, okay, how do I grow? So say, JB, you are at a hospital that doesn't have students. What do you do?
Oh, I mean, I lived on students at my last organization. I partnered with the local community college respiratory department. Uh, the um, the program director was a per diem of mine. And then I just gave them full access to the hospital and the department and supported them completely because I saw them as future employees. I didn't see them as a student. I saw them as like this person's going to be here going forward. Let's start them out off the right out of the gate. Let's start supporting them, giving them everything they need. And I did that by just opening every single door possible and giving them everything they wanted because I knew within a year and a half I'd be hiring that person. And it was just the quickest interviews because I already kind of knew them. They would all show up at my office for introductions, and so it was just easy. As soon as they come in, all right, this is the positions I have. Go days, nights, per diem, part time, whatever it may be. All right, see you in about 2 weeks for hospital orientation. It was very easy because I already knew them.
That easy.
They're not strangers at that point. I was known them for over a year already, and so that's I mean, it's just kind of a mean way to call it, but it's a feeder source for your personnel,
Yes.
right? So, but feeder. I always think of feeder fish, and like you just like one bigger fish eating the other fish. So I don't really like to use the term, but that's what it's called out there. But really, that's kind of what you're doing.
It's a minor
Support
league
from the
program,
beginning.
right?
There you go.
Yeah. Yeah.
So JJ, Jonathan walks in to your advisory board and says, "Hey, I want your students, and this is what I'm going to do. I'm going to give you and your students full access." Would you fall off your chair? Would you
Yeah,
be
that'd be
like,
awesome.
would you just hug JB? He's very huggable.
Yeah, I mean, I would have some more questions for him. Like, we have some students that can't come full time. Can they come work for you in a different capacity and come to school at the same time? I would have some more questions for him, see what he could do, how much he's willing to invest into that farm system.
When we didn't have positions, these were definite guaranteed hires. We had volunteers, and so I'd have new grads if I didn't have open positions volunteer, just so they can stay in that hospital. And then the next time the position opened, then it was automatic. They kept that FaceTime going. They dedicated themselves for showing up a couple times a week to volunteer. No brainer.
So, I think that we've solved a little bit of a problem. I think that, we're not only looking at problems, it's controversial. We're calling people out, we're holding people accountable, which I think is important. I think we gave some solutions today. I think the department and the school need to be best friends, which I also don't see all the time. We need to have students that are engaged in their own learning. Okay. So it's everybody's engaged, everybody's accountable, and that would create the culture that's going to get us where we need to be. Final thoughts? Anybody jump on in?
Well, one of the things that we talked about is are you hiring students or are you hiring new grads? And some facilities are full. That's fantastic if the facility's full. But if you're already full, so you can't hire new grads, I would look to see like when's the last time you hired somebody with, or how long have your staff been there, right? Because if you have a staff that the minimum experience level at that facility is 3 to 5 years, then you haven't hired anybody in that time frame, which I think is a rarity, but it can happen. You don't have the opportunity to bring in this new blood. And so are you making or creating opportunities to bring in new experience or different experienced new hires?
What I'm seeing around Southern California, which I find interesting and troubling, is that hospitals will not hire you with less than 1 year experience. But
Yes.
why that bothers me is you take students. And so you're going to tell me that you're going to have students come to your hospital for their clinical rotations, leave, get licensed, and then they're not welcome back. It's not a good sign.
Yeah, we had a lot of fresh graduates from California come to Ohio to work because we hire new grads. We have to hire new grads. That's how you get new blood. That's how you get new enthusiasm. They come in, they want to work, they want to learn, they want to grow. And we need that in every single department in the United States. Every single hospital needs new grads. They just bring so much more to the department and to our patients. And that's what's important. You want our patients to get the best care, and they bring that new evidence-based practice that the older therapists might not be up to date on.
No, and that's my final thought for today is students are different. You know, JJ's teaching them how to be humans. Jonathan's hiring humans.
Yep.
You want to work alongside humans, not here's your doing that, because Jonathan knows how much I love doing that. It's about creating the next generation. The next generation can't be a carbon copy print of the 1990s, because to me, that's what's being taught today. So I love this conversation. Call to actions absolutely has to be evaluate your department, evaluate your school. Do you have the culture to fill these gaps? And if you don't, fill them.
Yeah.
And there's plenty of resources out there. Come on, RT Sidebar, listen to us, give us some best practices, give us some shout outs. What a fun episode. Mindy, there's a couple call to actions. Why don't you take it? I think we have a next pod coming up.
Next podcast, JB's interview with Linda, and
Linda knows that.
the only one, the only asthma lady. Sorry, I can't see the screen from this far. I don't have my readers on. And they're going to talk about asthma education. And then the next one is, if I can see.
Oh, I wrote that down. I'll take care of it.
Okay.
There you go.
It's all you, because I can't see that far. I have good vision at this distance, guys.
Thank God I typed this. So
I'm going to squint.
So one thing that's really important for us here at RT Sidebar, Respiratory Care Week's not long enough. It's got to be Respiratory Care Month, because we like it all month long, all October. The first celebration is October 2nd, and that is with our good friend, Michael Sheehan, RT Sidebar guest, lawyer extraordinaire, and he's going to be talking about ethics, so that's going to be pretty awesome. JB, let's get it started on shout outs.
Well, joining me on the episode with the asthma lady is going to be Nadia and Jamie from Eisenhower Medical Center, both AECs, which we all know is a very, very difficult board to pass. They really put their heart and soul into this, and it's just good to get some more asthma awareness out there and education. So yeah, that's my two shout outs. JJ?
You know, I have to go back to one of those Californias that kind of fled to Texas, and because he could not get hired. David Zuniga, he's probably the biggest brain that I know around bubble mapping. He's amazing with it. I love that guy. Shout out David Zuniga.
That is awesome.
Yeah.
Yep.
I'm going to shout out, since we're talking about preceptors, I'm going to shout out to all the amazing preceptors out there who go above and beyond to make sure that our students have a good clinical rotation. So bravo to you guys.
I love that. And my shout outs are to the education that you and I and all of us have been able to be a part of. Big shout out to the Pennsylvania Society for Respiratory Care, where Mindy and I are at right now. We are Penn State, and we are not the Ohio. Also, a big shout out to Maryland DC Society. Conference by the Sea was fantastic. You and I are going to be in New Jersey coming up. We're going to be doing the same thing with JB and JJ, probably talking to some great leaders in the New Jersey, Delaware, Philly area. So that's what I have. Did you guys have fun?
It was great.
It's a great time.
Man, I love this.
We could do this every day, which we might, because this is a better part of my job. I love this. So Mindy, thank you so much for being a part of us. JJ, the RT, And as always, Dr. JB, he's snuggly. We give him
Oh.
hugs. Thank you guys for being on RT Sidebar. Stay. Go ahead, JB. Stay.
Tuned.
Hey.
Hannah, play the music.
Vapotherm does not practice medicine or provide medical services or advice. Any clinical recommendations provided herein are solely those of the speaker. Practitioners should refer to the full indications for use and operating instructions of any products referenced before use. Pelvichco and Hayes are employees of Vapotherm. Butler is a paid consultant, and our guest is not compensated.